Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/QYU. This activity is supported by an independent medical educational grant from AbbVie.
Hello, I'm Diana Ionescu from University of British Columbia, Vancouver, Canada. Welcome to this activity, Scoring Folate Receptor Alpha Expression in Gynecological Cancers, an interactive pathology masterclass. In our first presentation, we'll explore why accurate folate receptor alpha scoring is critical in tubo-ovarian and peritoneal high-grade serous carcinomas, advances in treating folate receptor-positive cancer, and outline scoring methods and their impact in treatment decision and reporting. I'm pleased to be joined today by my dear friend and colleague, Martin Koebel, from the University of Calgary in Alberta, Canada. Folate receptor alpha is a protein that's encoded by the FOLR1 gene, and it's expressed in epithelial ovarian cancer. 35 to 40% of the platinum-resistant high-grade serous ovarian cancer patients express high level of folate receptor alpha. The expression is higher in serous ovarian cancer as compared to other histologic subtypes. Folate receptor alpha is a predictive biomarker. In other words, it guides therapy selection rather than determining prognosis alone. If we look at transcriptomic analysis of folate receptor alpha expression, we can see that in normal tissues, the expression is limited as compared to the expression in ovarian tumor, in which folate receptor alpha expression is upregulated. I also want you to pay attention to one normal tissue, the fallopian tube. There is a slight expression in this normal tissue, and you'll see later on why this is important. Folate receptor alpha staining in ovarian cancer can be seen both in the membrane and in the cytoplasm. And ovarian tumors express folate receptor alpha in a combination of membranous and cytoplasmic staining. By comparison, there is no membrane or cytoplasmic folate receptor alpha protein expression in the normal ovarian tissue. Martin, what are the specimen requirements and fixation consideration for accurate folate receptor alpha staining?
Just to provide some context, so what is folate receptor alpha? It's a membrane-bound receptor which is expressed in epithelial cells, specifically of the fallopian tube and ovarian cancers. It mediates folate transport into epithelial cells. And it's an attractive target because its expression is limited on normal cells. And as indicated in the image below, it's highly upregulated in ovarian cancers, but also expressed in other tumors like endometrial and triple-negative breast cancers. Regarding the specimen requirements, so in the context we're talking about here is epithelial ovarian fallopian tube type and primary peritoneal cancer. What we need is archival or fresh tissue from resections, excisions, or biopsies, preferentially the newest specimen. Regardless, whether it's from the primary site, the presumed adnexal site, or metastatic sites such as the omentum. And as for other biomarkers, the specimen should be fixed for 12 to 72 hours with 10% neutral buffered formalin, paraffin embedded. And the section should be applicable for immunohistochemistry at a section of 4 micron and placed onto positively charged slides. Diana, how do the NCCN recommendations reinforce the importance of testing for folate receptor alpha in ovarian cancer? And which is the approved FR alpha testing system?
Well, in my opinion, it's very important for the pathologists to be familiar with the drug label and also with the guideline recommendation from NCCN, for example. NCCN guidelines show that mirvetuximab is an acceptable recurrence therapy for epithelial ovarian cancer, fallopian tube cancer, and primary peritoneal cancer. What the drug label shows is that the patient should have folate receptor alpha expression in at least 75% tumor cells What's important also is the validated molecular testing should be performed in a CLIA-approved facility using the most recent available tumor tissue. Also, we can see that the recurrence therapy for platinum-sensitive disease, it's mirvetuximab. And again, by looking only at the drug label, we can learn as pathologists the important clinically cutoffs, which are 75% positive tumor cells, and also the 50% positive category, which may become important at a later date. The approved folate receptor alpha testing systems are several. However, what's important again, it's to know which are the FDA-approved companion diagnostics. And when it comes to folate receptor alpha, the Ventana FOLR1 RxDX assay, it's the one that's FDA-approved. This uses a mouse monoclonal hybridoma antibody that's produced against a recombinant protein, as well as a cell culture supernatant, and it's purified using protein G. The antibody demonstrates both cytoplasmic and membranous staining, but only the membrane staining is evaluated for the determination of folate receptor alpha status. Martin, do you think you can walk us through how folate receptor alpha expression is assessed using immunohistochemistry in routine practice?
Certainly. So as you mentioned, the folate receptor 2.1 RxDX Ventana assay is the FDA-approved companion assay. And it's highly recommended to use normal fallopian tube as the internal control, which can be preferentially an on-slide control. The advantage of normal fallopian tube is that you have an positive control and negative control included. Namely that folate receptor alpha staining should be negative in the fallopian tube stroma and should be positive at the membrane of fallopian tube epithelial cells, preferentially at the apical or basolateral membranes. And that would indicate an acceptable positive staining. Not acceptable staining would be if there would be nonspecific background staining in the stroma or only weak membranous staining in fallopian tube cells. The other advantage of the fallopian tube is that one can gauge the intensity seen in the tumor specimen against the relative constant expression seen in normal tissue, specifically the 2+ and the 3+ intensity.
This really is an ideal external control, having negative, 1+, 2+, 3+ in the same tissue section.
I completely agree. Here is a challenge question. The detection or the interpretation of folate receptor alpha should be performed by pathologists with training in the evaluation, preferentially by a reading group, which allows for second opinion in difficult cases in order to reach a consensus. It predominantly focuses on assessing the intensity of the membranous staining in the epithelial tumor cells in a grade from 0 absent staining, 1 weak, to moderate to 3 strong staining. And the reporting at the end will be a binary reporting. So a case will be either positive for folate receptor alpha, and for positive case, the case must show at least moderate 2+ or strong 3+ staining and a distribution of 75% of viable tumor cells. Everything else falling short of this threshold will be considered a negative case. Obviously, artifacts such as necrosis should be excluded from the interpretation. And as many other biomarkers, one need a minimum of 100 viable tumor cells in order to be able to interpret the FOLR alpha status correctly. And just to reemphasize, it's important to be aware of the approximate prevalence that has been reported in clinical trials, which is around 36% in tubo-ovarian high-grade serous carcinoma for positive expression of folate receptor alpha.
I look forward to discuss such cases with you.
Here's another challenge question. So just to summarize the implication of FR-alpha score and treatment opportunities, FR-alpha is a clinical actionable biomarker in tubo-ovarian and peritoneal high-grade serous carcinoma. Validated IHC assays are essential for accurate detection, and the scoring is based on percentage of tumor cells which at least 2+ and 3+ staining. And the accurate interpretation is critical to guide patient eligibility for targeted therapy. Thank you, Diana, for the insightful discussion. We talked about the principle of folate alpha detection and scoring. Now it's your turn to apply them. In the following cases, you will review IHC images, consider how you would score them, and then we walk you through the correct interpretation together. Thank you for listening to this presentation.
In case 1, we have a 60-year-old female patient diagnosed with high-grade serous carcinoma of fallopian tube origin. Before we dive into the immunohistochemistry staining together, I would like you to score the folate receptor alpha yourself first. How would you interpret the patient's specimen? Please choose one of the following options. Great. Let's now look at the immunohistochemical stain together. This case represents a high-grade serous carcinoma involving the fibrated end of the fallopian tube. The adjacent fallopian tube epithelium serves as an excellent internal control. In the luminal aspect, we can appreciate staining of at least 2+ intensity with a mixture of 2+ and 3+ staining. Additionally, weaker 1+ staining is present along the lateral membranes of the fallopian tube epithelial cells. Turning to the tumor itself, the entire high-grade serous carcinoma demonstrates membranous staining of at least 2+ intensity, with the majority of the tumor cells showing strong 3+ staining. Now, that's what we appreciate at the lower magnification. At the higher magnification, we can better assess staining intensity and patterns. The 3+ intensity is defined by strong membranous staining. In areas of highest expression within the tumor, the membranous staining may appear partially obscured by additional strong cytoplasmic staining. However, remember that the key feature remains the circumferential membranous pattern. In contrast, within the normal fallopian tube epithelium, 3+ intensity is typically restricted to the apical membrane. It is important to note that partial membranous staining, such as apical staining, is still considered when estimating the proportion of positive tumor cells. You may observe faint 1+ staining along the lateral membranes of the fallopian tube cells. This weak staining should not be included when estimating the percentage of tumor cells meeting the 2+ threshold. Finally, the stromal cells serve as appropriate control for no staining or 0, and this is your negative internal control. So if we zoom in further, in the fallopian tube epithelium, 3+ intensity is seen predominantly along the epithelial the apical membrane, representing partial membranous staining. In contrast, within the high-grade serous carcinoma, 3+ intensity is circumferential, reflecting strong, complete membrane staining in tumor cells. There are also minor areas within the tumor that show slightly lower 2+ circumferential membranous staining, which is comparable in intensity to the apical or partial staining observed in the fallopian tube. Importantly, for final interpretation, it is not necessary to distinguish between 2+ and 3+ intensity, nor between circumferential and partial membranous staining. Both of them are included when estimating the proportion of tumor cells demonstrating high expression. In this example, the tumor shows predominantly 3+ staining, with only a small component of 2+ intensity, and overall, it demonstrates widespread membranous staining. Therefore, this case meets criteria for folate receptor alpha positivity, defined as 2+ or 3+ staining in 75% or more of tumor cells. The correct answer is folate receptor alpha more or equal to 75% of tumor cells with at least 2+ intensity. Now, is this a challenging case? Not really. So therefore, the opinion of a second pathologist is not really necessary. However, you have to be sure that you report this clearly and state this is a positive case. And it's optional to include the percentage and the intensity that supports your interpretation. The result should be clear for the medical oncologist. This is positive, folate receptor alpha, more or equal to 75% of tumor cells with at least 2 intensity. Here is a challenge question. Thank you for watching.
In case 2, we have a 63-year-old female patient. The histopathologic examination demonstrated a high-grade serous carcinoma involving the ovary. Before we dive in to look at the immunohistochemistry staining together, I would like you to score folate receptor 1 yourself first. How would you interpret this patient specimen? Great. Let's now look at the IHC stain together. On medium power, uniform 3+ membranous staining is apparent. The membranous staining pattern is circumferential and in minor foci and apical parts partial in the majority. It doesn't matter. Any cell with either circumferential or partial staining will be considered positive. In this high power field, there are a cluster of tumor cells which absent staining score 0 and only focal partial staining score 1 intensity, perhaps the apical membrane. The majority of tumor cells show partial 2+ or 3+ staining, but the distribution in this field would not reach 75%. So the results for this particular field would be moderate expression of 2 to 3+ intensity in more than 50 but less than 75% of tumor cells. However, in other high power fields of the same tumor, there are tumor cell clusters with partial apical staining. All cells of the periphery stain at least with one membrane for folate receptor in 3+ intensity, and these cells are considered positive. However, within the larger clusters in the center, there are a few cells that only show faint 1+ staining or no staining, and these cells would be considered negative for the distribution scores. However, the overall number of tumor cells with 2 or 3+ staining of at least partial membranous staining is still above 75% in this field. And since the vast majority of fields show this staining pattern, the final result for this case would be positive for folate receptor 1 staining, at least 2 or 3+ in more than 75% of tumor cells. So for educational purpose, the correct answer option here is folate receptor alpha borderline 75% with at least 2+ intensity. So this case is an example where one should consider to show the specimen to a second pathologist to reach consensus. While this borderline case is a useful teaching concept, it is not a reporting category. So after consensus is reached, the final report should be binary, positive or negative, to be clearly reported to the oncologist. Thank you for watching.
In this case, we have a 60-year-old female patient diagnosed with high-grade serous carcinoma involving tubo-ovarian or peritoneal tissue. Similar to our previous episodes, before we dive in to review the immunohistochemistry together, I would like you to go and interpret folate receptor alpha staining on your own. How would you interpret the patient's specimen? Could you choose one of the following options, please? Great. Now that you did that, let's look at the immunohistochemical stains together. At this medium power, we can see a predominant dotted staining without any linear membrane accentuation. You can really appreciate that even at this medium power. But it's much easier if you go at the higher power. You can see this predominantly dotted staining, and again, there is no linear membrane accentuation, not even partial. At the medium power of this particular case, you can also appreciate that there is a lot of necrosis, and the 3+ staining it's mostly present in the necrotic tumor debris. This represents artifactual staining or non-specific staining. Sometimes it resembles the Golgi type staining, as we saw in the first photographs, and it's a critical principle that only membranous staining should be considered for staining. These artifactual stainings that we saw in this micro episode should be excluded for interpretation. So for this particular case, the correct answer option is folate receptor alpha less than 50% with any intensity. The areas of artifactual staining should be acknowledged but excluded from interpretation. Now, should you get a second opinion? Of course, I have a very low threshold on asking another colleague if I'm uncertain on some interpretation, especially when I start interpreting a new predictive biomarker. Is it worth to repeat the staining on another sample? In clinical practice, if the artifact significantly interferes with interpretation, one may consider repeating the staining. So you can put in your report that interpretation is difficult because of the artifactual staining and recommend restaining if another specimen is available. Thank you for watching.
In case 4, we have a 60-year-old female patient. Histopathologic examination demonstrated a high-grade serous carcinoma involving the ovary. Before we dive into review the immunohistochemistry staining together, I would like you to interpret the folate receptor alpha staining pattern on your own first. How would you interpret this patient's specimen? Please choose one of the following options. Great. Now let's look at the IHC stain together. On medium power, most of the tumor cells show nearly circumferential membranous staining, which is 2+. Well, some microcysts show luminal staining, and we can also appreciate some larger droplets, which represent artifactual Golgi-like staining. In some areas, there's 3+ staining. On higher power, in this field, we see 2+ staining in some cells with circumferential membranous staining and some foci of even apical 3+ staining. However, there are cells without membranous staining, score 0, and with some partial 1+ staining, which should not be considered when estimating the distribution of staining. So in this field, the 2 and 3+ staining intensity would not reach 75%. However, most of the high power fields show tumor cell staining with at least partial 2+ or 3+ staining intensity, as shown here. It is also important to emphasize that we do not need to distinguish between 2+ and 3+ for scoring purposes. The simplest threshold is at least 2+. Notably, in this field, there are some Golgi-like droplet staining, which should not be included in the interpretation because they do not represent clear linear membranous staining. However, in this case, more than 75% of tumor cells show at least 2 and 3+ staining. Therefore, this case is interpreted as FR alpha positive. So the correct answer would be FR alpha more than 75% of tumor cells with at least 2+ intensities. This case may be also considered to get a second opinion given there's some staining heterogeneity. And hopefully the consensus will be that this case is clearly positive and the binary reporting should be conveyed to the oncologist. Repeat staining would not be necessary. Thank you for watching. In case 5, we have a 71-year-old female patient. Histopathologic examination demonstrated a high-grade serous carcinoma involving the ovary. Before we dive into review the immunohistochemistry staining together, I would like you to interpret the FR alpha staining pattern on your own first. How would you interpret this patient specimen? Please choose one of the following options. let's look at the IHC stain together. In this medium power view shows that approximately half or slightly more of the tumor cells show 2+ or 3+ staining, but a vast proportion of the tumor show absent staining or 1+ staining. On higher power, as seen in this field, there's only focal 2 and 3+ staining some of these apical aspects of microcystic spaces, which should be included in the interpretation. But in this particular field, the majority of tumor cells show absent or only 1+ staining. Again, there are droplets which cannot be clearly assigned to a membrane, which should not be considered for estimating the distribution. So in this next high power field, only focal 2 or 3+ staining is seen. The vast majority of tumor cells show absent or only 1+ staining. So overall, the final result is negative because in this tumor, the required threshold of 75% for 2 or 3+ staining is not reached. So for this case, the correct answer option is FR alpha more than 50 but less than 75% with at least 2+ intensity, as per our impression from the initial medium power field. Therefore, despite the presence of moderate and strong staining in some areas, this case does not meet the criteria for positivity. So the overall interpretation is negative. So this case highlights an important point that strong or moderate staining alone is not sufficient, but the percentage distribution threshold criteria must also be met. Is a second opinion required in this case? In my opinion, not. However, it would not hurt to show this case a second pathologist if in doubt regarding the droplet, like Golgi staining, for example. Repeat staining is also not required. However, I want to re-emphasize it's important to clearly communicate this as a negative result, ensuring that the oncologists understand that the specimen does not meet the criteria for FR positivity and the patient is therefore not eligible for this targeted therapy. Here's a challenge question. Thank you for watching.
In case 6, we have a 72-year-old patient, a female patient, diagnosed with high-grade serous carcinoma involving peritoneum. Before we dive in to review the immunohistochemistry together, I would like you to go and interpret folate receptor alpha staining on your own. How would you interpret this patient's specimen? Please choose one of the following options. Great. Let's now look at the immunohistochemical stains together. At this medium power view, you can appreciate a typical mixture of 1+ to 3+ intensity in the tumor cells when we look at the staining for folate receptor alpha. However, less than 10% of the tumor shows 2 or 3+ intensity. The asterisk in this picture indicates the debris, and we learned on a previous episode that this is an artifact, the artifactual staining, and it should not be included in the interpretation. For this case, the correct answer is folate receptor alpha less than 50% of tumor cells with any intensity. This case is therefore folate receptor alpha negative. The result should be clearly reported as negative, and there should be no ambiguity in your communication of this result, because it's important for clinical decision making for the oncologist to understand this is a negative result. Although there are areas showing variable staining intensity, including occasional 2+ or 3+ staining, these staining patterns are present in less than 50% of viable tumor cells and therefore do not meet the threshold for positivity. I don't think this is a difficult case. So I wouldn't ask a colleague for a second opinion. Of course, you can show it if you really think your particular slide or case is difficult. And no, I would not repeat the staining because I think it is quite straightforward. So thank you for watching these sessions. We appreciate you learning with us.
This has been an activity published by Peer Voice.